welcome everyone. For those of you who have turned up, we are really looking forward to Carol Hardy's presentation today on the SUSI model. We will be making a start in a few minutes. For those of you who aren't familiar with the Supporting Early Minds Research Network, we are a virtual England-wide research network funded by the NIHR to help improve research capacity across all 0 to 5 services. We'd be absolutely delighted if you would join our network. The QR code is on the screen now, which takes you to the Join Us or Join the Network page. The web page, the main website is down below, so it's www.supportingearlyminds.org.uk, and our email address is below. Just to show you, we have this is what our website looks like, and if you are from a 0 to 5 service, we have got a 7 pages that talk about the research process. The bottom page, setting priorities for research, is slightly separate, but we've got a lot of resources on there, including downloadable checklists that you can take away and discuss with your team and your managers about how you might get involved in research. Okay, so without further ado, I will hand over to Carol, and we will have answers, question and answers and comments from about quarter to 2. Okay, Carol, I will let you introduce yourself.
Thanks very much, Michael. Good. Can you see that okay?
Yes, we can. Thank you very much.
Lovely. Thanks, Michael. Thank you. Well, just to thank you, first of all, for inviting me to speak today. I'm really looking forward to presenting some work, but then also having time to hear people's thoughts and, you know, views and you know, perspectives on this work, particularly from a clinical and a research point of view. So my name's Carol Hardy. I work in SLAM, and I'm a sort of under 5s CAMS lead from a service perspective, and also a sort of infant mental health specialist from a clinical perspective. So I've worked in under 5s CAMS for a few decades now, but in more recent years have really created this framework that has become known as SUSI, so probably in the last sort of 15 years, and I'll just describe its history very, very briefly in the sort of coming slides, and the different components. And then just more recently in 2021, in the sort of January 21, in this sort of middle of the pandemic, I started a new under 5s borough service here in Southwark in South London. So that's been also a very very interesting and different experience to perhaps previous under 5s services I've worked in. I also have a foot in a CAM service for looked after and adopted children, which I worked in for many years full time, and I do some work across other boroughs, helping to develop services and projects for under 5s there. So just very briefly, this is what I was aiming to cover. I know it's probably a bit of a big ask, but I wanted to introduce the background to the SUSI model from both a clinical and a research point of view. That will probably focus particularly, as much of the sort of my day-to-day work over the years and the research has done, is particularly focus on more underserved at-risk 0 to 4s and their families. Briefly touch on the sort of scale of the need, which I think we're all very familiar with and probably very concerned about at many levels, and thinking about ways that we can sort of work more closely across agencies. I'm then going to introduce the SUSI clinical science framework, which was a component of the SUSI model, and just introduce that and describe a few of the findings. Think a little bit about training and consultation, which is quite a significant part of my service and also of the model, and of a under 5s CAMS care pathway, which I wrote in SLAM with colleagues. And then if we can maybe touch on some case material for, I've got an example, a sort of composite example of a sort of parent and child who presented in a very disorganized way. Michael and I just spoke briefly at the beginning of this webinar to say that I think we will, I will sort of show slides, but they will probably be redacted for the video recording, just even though these are sort of composite examples, that seems right to do. I wanted to also just acknowledge that so many people have worked with me over these many years, and I will mention some. I'm sure I will miss some, but I'll try and thread them through as I sort of go through, just to really acknowledge this sort of huge amount of support and ideas and shaping of this work that has also come through really close colleagues. Probably one person I'd like to just mention immediately is Elizabeth Murphy, who is a consultant child and adolescent psychotherapist, and she was really my sort of joint lead on all of the research studies, the 2 research studies that we did on SUSI in the last sort of 15 years, and she was our lead clinician. So I won't really speak to this, and I really just borrowed quotes from this really excellent Parent Infant Foundation commissioning toolkit to really illustrate that there are so many babies, as we know, that we are not seeing in services and who are out there sort of hidden in the community. We know that they emerge at later points in time, sometimes as early as 3, often much later in their childhood, and sort of how can we sort of try and improve our offer and make services open and accessible to actually sort of draw families and other professionals in, because I think as much as there's very obvious worry and concern for families in coming into a CAM service, mental health at such a young age, I think there's also many barriers in our professional systems about the sort of worry about what that looks like, and also sort of probably just lack of knowledge as to what we would actually be doing with families. So I think that a lot of my work has really been involved with families like this, working in services where we would get a trickle of referrals, and then as our colleagues in the community and other adult mental health services became more confident in what we were offering, service referrals would then sort of really increase. So I think it is possible. There are ways to do this, and certainly in SUSI that was our really big goal, was to try and reach out in a much more sort of proactive way to these at-risk populations. So these are not families who are saying they are worried necessarily at all. They're not asking for a service, but it was very interesting in the SUSI research component of this talk. I can just describe briefly who did we reach out to, and how did that happen. So the clinical approach has really been developed from many years of clinical work in services. I used to work up in the north of the borough at Guy's Hospital, and you might think that was quite off-putting for families, but actually the local families in that area just treated Guy's Hospital like their GP surgery, so they were very happy to come into a sort of clinic on the edge of the hospital site there, and really at that time, with colleagues, I'd like to mention Bernadette Kiley, who was a sort of huge influence on the shaping of this sort of parent-infant work. We were at that time working within a much more structured parenting program offer, and I think that and it did have very good aims, and it had sort of attachment sort of thinking and approaches within it. But I think what we noticed was that many of the parents really struggled to translate ideas from the group program into their actual relationship with their child. And we knew that because we were actually seeing the parents in the group program. We also had the children to look after. And so we could sort of see immediately what was possible and what wasn't possible. I'm talking about parents with, huge amounts of adversity, and often with very little sort of services and support around them. So I think that we adapted this sort of parent-infant approach and took it into outpatient work, did quite intensive outpatient work with parents and infants over many years. And then more recently, when I joined a service for looked after and adopted children, Elizabeth and I run the first of the research studies, which we called the pilot. And so this was only with looked after children. Well, on the face of it, we actually had children with birth parents in foster placements and residentials. So the span of kind of families kept on expanding in many ways. And we basically were very aware that we were an open service for any age of child. They didn't have to have a diagnosis, a set of symptoms, but we were still getting almost no under fives referred. So the pilot basically reached out, and we saw 97% of the looked after children in a 12-month period through lots of great networking with paediatrics and social care. And that really just sort of showed up this enormous amount of need in the sort of emotional world of these children and in their relationships with whoever caregiver they were with. And I think because we'd trialed it with this population, and then we found that we were working with lots of other groups, birth parents, aunties, grandmas, kinship carers, adopters. The SUSI study was developed further and was called SUSI at that point. And then we really targeted these community groups. And there were other community groups that you would probably obviously think of, like Children in Need and, perhaps perinatal. But we had these three groups we decided to focus on. So children on a child protection plan, CP, children whose parents were within a parental mental health team, which is quite a unique team here. It's a kind of threshold below perinatal, but still has families with very, very complex needs. And then the looked after children again. And this was a very strong partnership model, which I can talk a little bit about, but we'll come back to it as we thread through. So there were very clear timelines in terms of when we fed back to other professionals, and that was all very transparent with families. I mean, it varied according to the group. So this is a sort of very brief diagram of the SUSI process. It's very similar to the research one. The first box would have said consent rather than engagement, but of course it had both consent and engagement as part of it in the research. And I'm very happy to talk about some of these in more detail. I'm going to do a whistle stop today, but I want to sort of also respond to what's most helpful for, or what's more interesting, I should say, for people who've joined the webinar today. So I'm happy to come back to things and describe them more. But we had a sort of structured sort of assessment, which was delivered flexibly in any location. That was very important in order to reach these families, and it had a mixture of standardized measures and sort of clinical observation, which also included the SUSI signs, which I'm going to describe in a bit more detail. And then the feedback was oriented in such a way, and we still write our reports in this style, to be child and parent-child relationship focused, but very sensitive to who are very worried, anxious, and quite often parents with mental health problems. So we wrote these reports very briefly compared to a standard CAMHS report. We wrote them in very ordinary language, and we tried to sort of bring the parent with us in the narrative in a way. So I think people that I now train in order to use this approach kind of really get into this sort of style of writing, which I think has been really key in helping parents to sort of come on board. So we had very positive or accepting, I should say, feedback from parents where they would say, yes, that's right, or yes, you've hit the nail on the head. They may not have loads to say, but they were sort of like saying, oh, that's a relief. Somebody's actually sort of said what it is that I'm experiencing. I'm going to come on to the intervention as we go through the slides. And then also these last points were the communication with the network was really throughout, very actively communicating with the network and sharing reports, and also then sharing ideas that other professionals could put into practice in their their own roles, say a social worker visiting, etc. So these are the challenges. They remain the challenges, don't they? For us to, how can we identify babies and young children at an earlier stage in a sensitive manner, but in a really kind of in a robust way that we can improve the lines of referral, improve the sort of lines of communication with us and our colleagues in the community and other services. How can we engage and support parents? I think part of the SUSI model was to break things down into sort of smaller chunks, and this definitely helped some parents to engage, knowing that it wasn't necessarily a very long-term intervention was a plus to some degree for parents. I think they felt they could see a beginning and an end. And also, I think to in a way find the language to reach out to our partner agencies and colleagues so that they also would be open to looking at this child's distress, perhaps for the first time and also perhaps in different ways. We wanted to influence that sort of care planning across the system, joining together and, obviously hearing and learning from other colleagues of their views, but also really bringing to light, which was a commenter IRO once meant you've brought the child you brought the child into the sort of picture, brought them into the light. And then I think features for us was we knew that we weren't going to be able to do very long-winded assessments. These families were not going to accept that and engage. So all of the features were really designed to be the most sort of doable, and also in terms of where and when. I'm going to come back to the intervention, so I won't describe that just now. I just put this up very briefly because I think because of some of the work that we've written up, it probably tends to focus on a particular group that looked after children or the children with CP, but I wanted to show you the breadth in a way of the sorts of parent-child dyads that we worked with and who this model sort of could reach. So many of our families are mums and dads living in the community, and so it really stretches across a sort of large continuum, even though that these are more vulnerable families, as a wider sort of cohort. I'm very happy to talk about how the model would vary and be adapted to these different sorts of scenarios and locations as well. So Elizabeth and I wrote up a clinical handbook, and I think I just wanted to say that what we wanted to share was sort of some of the more practical elements of how did we actually set up this system to work so closely with other agencies. So there are aspects of the book which actually touch on that and on how those relationships were formed and maintained. How did we sort of problem shoot? There were obviously lots of issues that come up, not least things at the further end of complexity around the legal system and so on, but really all along the way. And then there are big chunks of the book which are really about the sort of clinical approach, both the assessment and trying to break down some of the clinical techniques, hugely informed by infant mental health, geniuses, Selma Freyberg and Alicia Lieberman and many others. So this does definitely have sort of crossover with parent-infant psychotherapy. It also has a very strong developmental lens, and you'll see from the SUSI signs about the sort of different ways we were looking at and trying to understand how children were presenting. So I'm going to just checking my own timing. I'm going to just go on to describe a little bit about the SUSI signs framework. So the question is, what do signs of social emotional difficulty look like in babies and young children? I think we had decided at the beginning of both the studies and certainly from within clinical work previously that we were going to try and write a sort of formulation-based summary within reports and to feedback and discuss with families and other professionals. And this, I think, proved very helpful because I think it gave us that very wide open-minded approach to thinking about what is influencing this child and this relationship. And the great big sort of squiggle there on the page is really sort of, I suppose, symbolic of just how messy this can look in a way, and it can look confusing and contradictory. And in a way, that's I suppose that's also the hopefulness I feel like at this stage of a child's life and baby's life, that things may still be all very movable, and that we can actually try and change one thing and it has quite a dramatic effect on other aspects of a child's functioning, but it's quite hard to sort of grapple with. Before I move on to sort of show you what some of the signs look like, I just wanted to acknowledge that two colleagues, I think Karen Bateson may well be on the webinar, and Eva Sprecher, the three of us have joined together to write a paper which has just been submitted for publication, really describing this in a lot more detail. So I just wanted to really say a huge thank you to them, Karen, for your very great help in us bringing the narrative to a more coherent point, and for Eva for her amazing work on analysing the data. So from a sort of clinical perspective, the reason why I thought that this seemed like a useful thing to do within the SUSI study, the one that we did in more recent years with the 3 cohorts, that we had all this standardised measures. We had loads of well, not loads, but we had 4 standardised measures, and we had lots of sort of other more informal observations. But it seemed that we were going to be reporting on numbers and on graphs and so on like that, and I felt like the people that are the most hidden here are the children, the babies and the children. How do we describe them? Not in number form. So we went through the sort of 122 completed assessments. We had about 140 in the study, but we went through those 122 that were completed, and we really looked at sort of what were the children's signs of distress, of strength, and how did this sort of build a picture of what they were telling us about, how were they communicating their needs. And we were just having an open conversation, and as we talked, we kind of realized that they seemed to sort of fall into these sort of 5 categories. So just to say, I can take no credit for what I think is very clever PowerPoint slide. This was a wonderful AP who did this for me. So these seem to be areas of functioning where we could see that the child was showing us something about their difficulties and their distress. And the reason, so the 4 beginning ones, emotional, behavioural, functional, and physical, probably fairly self-explanatory. I just wanted to speak briefly to the child-parent interaction to say why we were actually describing how the child was interacting with the parent rather than how was the parent sort of responding to the child. The reason for that was that we had our main outcome measure, which was the KIPS, the Keys to Interactive Parenting Scale, where all of that information was captured, because as we know, there are many parent-infant interaction scales. They tend to be generally are often a bit more sort of parent-oriented. What is the parent doing in response to the child? So we wanted to devise this category, which is what were the sort of more repeating patterns of how this child was interacting with their parent. And across these 5 domains, it felt like we captured really most of the really key signs, and it might be that children had incredibly different numbers of signs according to their presentation at that time. Just bear in mind that half of our cohort were under 12 months, so we were working with a lot of babies. So we saw vastly fewer signs in the babies. We were very careful about how we would link signs to a particular case, so there had to be a really clear indication that we were seeing this on a repeating level. It was a sort of persistent sign that we could see over and over again, not just as a sort of one-off. These were, I suppose we saw a sort of thread developing for a particular child, often with quite contradictory type of presentations. So there might be a very solemn and sad affect on the emotional category, and then there would be inconsolable crying that you might see on the behavioural, and then you might see this say the inconsistent physical coordination, where you could see that the child could be coordinated, but at times would become very physically clumsy. So we included that one because it was a very prevalent sign actually, and it could be mistaken for the child's got a developmental coordination sort of disorder developing or something, and we're obviously keeping an open mind to that as well, but really trying to sort of pick up these very subtle signs of distress, and that they might sort of come in all sorts of shapes and sizes. So what we oh, sorry, it's decided to freeze, which is not helpful. Thank you. So these were the most prevalent signs, and you can see that at the top there is this sort of not signaling need. So I'm just going to say something briefly about the fact that, and I can go back to that signs page later if people wanted to have another look. But quite a few of our signs, you might have noticed already, are actually about a lack of something, an absence. So, generally sort of our health system is all about the presence of a symptom, isn't it? But I think in, this field, and probably you could argue perhaps with older children as well, I think you could, that you are also trying to understand why the child isn't doing something, why the parent and the child themselves are not doing things together. So that felt really important to flag up, and you could see these very high percentages, nearly 50% of these 0 to 6 month old babies were simply not signaling their needs. They were very withdrawn, passive, would have very, very little affect, very little communication with their parents and with anyone. You could sometimes see them come to life, if they were perhaps with another professional. The therapeutic stance that we took was to be very careful to try and engage the baby in the presence of the parent, and the parent would always be there, just because it has such an impact on how the parent's already feeling so often depressed or worried, or just lacking in confidence about their own interaction with their baby and how their baby responded to them. I was wanting to say just a couple of things, if I've got time, that in terms of the SUSI signs, I'm going to really give the credit to Eva here. She really looked at how these signs at baseline and at 12 months compared to the standardized measures. So in terms of at baseline, there was really good external validity with the standardized measures that we were using. So the KIPS, which was our main outcome measure, really trying to measure the quality of relationship pre and post intervention, and also the ASQSE, which we used but as a semi-structured interview, so it drew out a lot more than being given as a screening questionnaire. So there was really really strong correlations there between the SUSI signs and these external standardized measures. So with a sort of positive correlation, higher the ASQSE score, higher number of signs, and then a negative correlation with the KIPS. So the lower the quality of the parent-child relationship, the higher the number of signs. We also looked at ACEs, and so we were looking at sort of 4+ ACEs, and we had about 40% of our children, so these are under 5s who've gathered 4+ ACEs at a very rapid rate, and they also strongly correlated with the number of SUSI signs, so an increase in SUSI signs. Though I would just like to say that we found there was quite a variance in that group of the children with the 4+ ACEs. So it doesn't mean that they are necessarily going to have a higher number of clinical signs. We're not saying that there was quite a strong variation in that group. So we could perhaps come back to this more in the discussion in terms of sort of how this might be applied and how it could be used in perhaps any further work or research. I'm going to just say something briefly about the intervention. It's a tailored intervention, as I say. It's very strongly based on infant mental health, attachment and developmental kind of theories and evidence. I was trying to think how to say this very succinctly. There is a lot of the main focus of the work is often in this first section, the parent-child relationship live work. It's quite an active approach where we have the parent and baby or child in the room with us. And although we're using spontaneous play largely, we might structure it if that is helpful to the parent. We are really sort of focusing in on what came out of the assessment, what are the areas of interaction that are, could be built on more, what are signs of really maladaptive interaction where, either there's huge defensiveness within the child and or the parent, and there's very, very little happening between the two of them. I think that the live and very active work, it's paced. When I say very active, but it's very paced. Really sort of came from those many years of clinical work where we had parents who found it so difficult to stop and reflect. They didn't want to talk about their past often, or that would come much later. And therefore we were there with them, knowing that there were so many emotional underpinning to this relationship. We didn't want to just talk about behaviour. So we really had to find a way to try and help them move on. So the techniques that we used were sort of ones where, in a way you're creating opportunities in the moment. So they happen quite spontaneously, but the therapist is actually creating more opportunities with risk, because you can turn a child back to their parent, the parent may not respond, or the parent might become very upset. So you're sort of dealing with that sort of in the moment. But I think that where you see movement and where you see a parent being able to make that connection because they're being contained by the therapist to try something, many parents say, yeah, they're not going to do that with me. They don't like me, they don't play with me, etc., etc. But where you actually create something, I mean, it's such an emotionally powerful moment, and I think it has this ripple effect. So I think that often there's many sessions you're going over and you're building on the sort of work, but this is probably my best succinct description. It is tailored, so interventions start at different types of work. Some might start with more reflective discussion, but we do often start with the live work quite early on too. I'm very happy to answer more questions on that too. And as I say, we have tried to really describe that better in the book, or more fully. Just wanted to show this graph, which we've included some this in the paper, just to sort of look at what happens to these SUSI signs over time. So over a sort of 12-month period from baseline to 12-month follow-up. So if you can look on the sort of left-hand side where those two blue and red lines join. So that's the number of SUSI signs at baseline at the start of the intervention. And then those two lines digress. So the blue line is for families who completed less than 50% of the intervention, and the red line is for those that completed more than 50%. And I'll answer a question on that if it's useful, but I can say why we did it in that less than more 50%. But what you can see is that for those families who didn't complete, the SUSI signs increased between baseline and follow-up. But for the families who did do the 50% or more, the SUSI signs decreased. Now, this would need more testing, but this was just something that came out from our sort of preliminary sort of explorations around the data. So it is a sort of possibility for the future that the SUSI science framework could be used for looking at sort of treatment effects, and certainly sort of, yeah, looking at how these signs sort of develop over time for families perhaps who don't also take up interventions too. I wanted to just give you a little snapshot of some of the training implications from SUSI, because it felt like we had, a lot of really rich material. We'd learned a lot about how children were presenting and how relationships were presenting. So we've incorporated some of this thinking with other wider infant mental health knowledge and evidence into a variety of training packages. Now, the level 1 is one that we delivered very, very widely to lots of partner agencies, and also have done one that I kind of call sort of 1/2, where we've done a sort of follow-up and sort of deeper level training with people who've done level 1. That's something that it would be good to do more of, and I'm really just sort of beginning to think about how that might be possible. And then there's also a level 3 clinical training on the actual clinical approach, using the assessment and the intervention and the networking. So that is something that I have delivered to a small number of other teams, so parent, infant, or under 5s teams. So that would be something potentially for thinking about workforce training, really, in the future. And then embedded within the work is this sort of consultation, which many under 5s teams do, and we do ourselves within the service here. So it's just a description of some of the people that we reach out to in sort of regular monthly slots and that we talk to individually. And then, yeah, as I say, thinking about possible future developments for levels 2 and 3 further. Now I've got 3 slides, so I'm going to do these really quickly. But this is some of the feedback. So we give people a series of statements at the beginning of the training, and then they answer the same statements at the end. So this is taken mostly from the level 1/2 training days. So it seemed, I suppose we probably all have this experience where we talk to people and they are really keen on this area, on this field. They want to learn more, but they really do lack confidence in sort of how to go about it. And I think this is why, well, things like some of the Leeds early observation tool, where I think that's going to be so helpful, opening up conversations with families. So there are many other very amazing approaches happening at the moment. So we asked a series of statements, and I just picked out 3. So the first one was, I feel able to recognise early signs of poor infant mental health and difficulties in a baby or young child. So then you can sort of see on the left-hand side the pre-training, and on the right-hand side the post-training. So people's sort of feeling that they had more knowledge and skill to be able to sort of recognise definitely sort of increased from pre and post. And then statement 3 was feeling confident, because that seemed to be something we'd picked up a lot about, confidence in having these conversations. And again, so the sort of blue, the strongly agree, sort of really increased from sort of pre to post, and which is obviously what we want to see. And then say the statement 6, actually, what are people going to take away? Are they actually going to feel they can take things away? We have done some further follow-up, but this was at the end of the training day, so people feeling they might have more skills to make a positive impact on the way a parent interacts with their child. So those were just 3 of the statements. Those are the ones I kind of feel like are really the meaty ones, in terms of people feeling they're going to take away something and actually be able to, integrate it into their own practice. Oh, I think we do have 5 minutes that I could describe this sort of composite example of a case. So I was going to bring just a description of a child who's around 18 months of age, who on paper was just described as screaming, head banging, you know, bites, hits, very overfamiliar with other people. So this is a family with large network of people going into the home. And it's also, this was an interesting comment from one colleague, that this child was also invisible in the home, despite having this sort of vast array of very, you know, negative and difficult behaviours. And so this child could also be incredibly silent. I think that we see that sometimes, don't we? There might be, you know, the way that the home's set up, there might be a sort of break in the room where, you know, you suddenly realize that there's actually a child sitting behind that section of the wall, just silently in a high chair. Well, that is this child. And a lot of focus on the mother, who was very, very traumatized. I'm not going to describe that just because we're talking about a kind of mixed presentation here of cases, but this will be very familiar to us to work with parents who have got huge levels of trauma right through their childhood into adulthood, repeated traumas, highly dysregulated, often talking about self-harm and threatening suicide in front of the children, and sometimes behaving in really sort of very dangerous ways. This particular mum that I suppose I've got in my mind more is a very bright woman too, so is sort of also can be very articulate, and that was something that we could see. You know, it can slightly discombobulate services too, in terms of them getting perhaps the right level of help, because this mum was stepped down quite a lot from services, and this was a sort of repeating pattern. So when we looked at the ASQSE score, which is the Ages and Stages Questionnaire Social Emotional, massive score. So this cutoff for this age group is 65. Now, we saw lots of parents who would, particularly say in the research in the CP group, who would score like 0 or 5, something incredibly low. We'd also see parents who would describe huge numbers of difficulty. So the score is not something that we take as in any way the indication of level of need. But in this case, this mother was very vocal about how many problems there were. And really, largely, when I wrote down the main points from the ASQ, you were really looking at a series of symptoms that screamed out ASD. And yet, when we saw this little child in clinic, we saw something really, really different. I'm not to say that there won't be neurodevelopmental issues emerging, possibly, but what we saw was this very, very frightened little child who had a whole range of very contradictory, very strange behaviours. He couldn't approach his mother at all. He really rejected all contact. If she reached out to him, he would turn away. He would look very frightened. His body and his face would become contorted and distorted, and very, very tense. So he was also very worried about mum leaving, despite the fact he couldn't go anywhere near her. So if she looked like she was even getting up from the floor to sit on a chair, he became panicked, very easily angered. So he would just walk up to us as complete strangers and want to sort of pinch us and sort of hit. So words, you know, I was very aware of sort of what words were being used in the room and how very, very sensitive he was to that. So I think that this is just an example of how the SUSI signs were, you know, felt more relevant for this little boy in a way. So we could sort of track really a large number of signs as well for this little boy, but it sort of painted this very different picture. And it was one that we could then share with the network. And it brought about a whole series of changes then in the care planning. So this child was heading to CP, in fact, went on to PLO, the public law outline for pre-proceedings. And although those were very difficult conversations, it also, I think, led mum to actually begin to eventually engage with us for an intervention, and they are actually engaged in a ongoing intervention using the SUSI intervention to really try and help build and repair a lot of these sort of relationship difficulties. So I'm going to stop there because I've noticed the time, and sorry, Michael, if you've given me a signal for time. I think it's about 1:45 now. I'm going to just move the slide on to these were just I can take this slide off as well, but these were just some sort of thoughts in terms of, I'd be really interested if people had any thoughts about sort of developing some of these things like level 2 training for people who are out there at the coalface, basically working with all of these very complex families, but needing some more training within a sort of universal targeted workforce, and then whether or not any people had thoughts about the sort of SUSI science framework. Be very keen to hear. And I think for me, and I'm sure for many people possibly on the webinar, really thinking about how can we expand parent-infant training in our workforce so that we have more people to actually join services. If we can build services, we also need a workforce that feel confident and skilled to actually deliver what is often very sort of complex and sometimes really quite risky clinical work. I'm just going to point out before I come back to Michael that I have written a bunch of references here at the end, and there are a couple of slides on SUSI outcomes, but I'm not going to show those. I'm going to come back to Michael and then see what's the next step. So I'm going to stop there. Thank you.
Thank you very much, Carol. Well, I'm just going to stop recording now.